corner but travels around the world? Stays in a corner but travels around the world. Stamp. Very well done. What kind of animal would you never play video games with? A cheetah. Very good. Let's see if we can get this one. Why was Tigger looking in the toilet? He was looking for poo. Very good. My kids thought that was the funnest. Why is it that the word poo is so funny in the middle? Still kind of funny. Some of you can't help yourself, including me. Okay. So a check on the syllabus. We're in respiratory for today and Wednesday. I did update the lecture. I know it seemed like it was last minute. You'll be fine. You can download it right now. You can take some extra notes. But I wanted to add in some information, new information, because we've had some big changes in where the CDC and the FDA are coming with respect to vaping. So I've updated new information. I actually have statistics for you that are only about 5 days old, and they're actually updated every week. That's how serious this has become. And I'll show you where you can find the information. But first, so we're in respiratory today and Wednesday, and then we'll have an introductory cardiovascular lecture on Monday of next week. And we won't have class on Wednesday of next week, which is the day before Thanksgiving. Okay? It's Thanksgiving Eve, as I would say. And so we should not have class. Okay, but we planned on this. We've got plenty of time to finish out respiratory, plenty of time to finish out cardiovascular. So that is our schedule. And then I want to draw your attention to December 10th. December 10th, according to the final exam schedule, in this room, which is a Tuesday, from 3 to 5 p.m. I think I've mentioned this before. The good news is if you come to class on Monday, you'll be likely the only one here. Or you'll be here with people you don't recognize because you're in the wrong final, okay? So don't take that final and excuse yourself, look at the syllabus and realize, oh, I'm a day early. And then the good news is you have a whole extra day to study, okay? So Tuesday, December 10th is the final from 3 to 5 in this room. You'll have plenty of time. I mean, we usually have an hour and 15 minutes, so most of you are done in that period of time. Any questions about the schedule?
Just quick, on the final, could you roughly give a percentage on like new material versus old? Is it like 80-20-ish?
Yeah, probably pretty close to 80-20. That's a good number. Does everybody like that number? No, that is the number, okay? Probably about 20%. So maybe 5 to 10 questions. That would be 10 to 20% review. 5 to 10 questions will be review content, okay? Average, maybe 7.5. I can't really do half a question, so there you go. Any other questions or comments? Okay. Respiratory diseases. So we're going to look at a couple of different categories, and then we're going to hone in today mostly on vaping because it's relevant in today's culture. But to give you more of a comprehensive view to start, we'll talk about atelectasis, which is basically lung collapse. And then we'll talk about obstructive pulmonary diseases and then restrictive pulmonary diseases. And then lastly, on Wednesday, we'll talk about infections. Now, what's interesting is if you read some of the vaping literature, and I've actually posted a peer-reviewed manuscript in 2019, that actually has histology. So when we have lung histology, what does that typically tell you about the patient situation? So they're either deceased or it's pretty severe because they've actually had to biopsy lung tissue. You can do a minimally invasive lung biopsy to see what things are and not have to sacrifice the patient. sorry, Mr. Johnson, we're gonna have to sacrifice your life to get a lung biopsy. They don't have to have that awkward conversation, right? So, but it means it's pretty serious if you're taking lung biopsies. We usually don't do lung biopsies until we're talking about cancer. And now we're talking about vaping and actually in teenage patients, in children. I'll show you one example today of a 17-year-old, which I think by law is considered a boy, even though he probably would hate me for calling him a boy. He's only 17, he's not quite an adult yet, okay? So, we'll talk about all these different categories and we'll look at some of the histology, and we don't have time to cover everything, but we'll be somewhat comprehensive, and where we're going to go deeper is into vaping, because I thought that would be an interesting topic for us. So let's do some review. Let's look at some of these terminologies. Like, you guys know that I enjoy making sure that we're all on the same page at some level. So eupnea, dyspnea, and orthopnea. So eupnea, this is a word from a Greek root, EU or eu meaning well, and noia, or with the P, P-N-O-I-A, is from the Greek meaning breath. You don't pronounce the P, it's silent. So noia, this would be well breathing, eupnea, or eunoia in the Greek, well breathing. That's normal breathing. So eupnea is normal breathing. Sounds like a disease, but it's not, okay? So don't be tricked by that. Dyspnea, what do you think this is? This is trouble breathing, or what we would call a shortness of breath, abbreviated SOB, right? Bless you. I remember, this is a funny story. I remember the first time I saw the acronym SOB. I was volunteering in a hospital ER setting, back when they called it the emergency room, and they call it the emergency department. And I remember seeing on the whiteboard, you know, SOB, you know, in these different rooms, like 4 of them. And then I heard one of the nurses walk by. In room 4, there's a really, really difficult SOB. And I'm like, wow, I'm not sure this whole medical field is for me. They're really harsh on what they're calling these patients. It stands for shortness of breath. It's actually not that they're, you know, defaming the patient, all right, in any way. So SOB, shortness of breath. Orthopnea, this is shortness of breath while you're lying down, okay, in a horizontal position. So you can imagine if patients have shortness of breath when they're laying down, it's more severe than if they're, you know, having shortness of breath when they're climbing stairs. All right, hyperventilation versus hypoventilation. Please define those for me. These are just straight definitions, but if you don't know these things, clinically, when you get into the readings, you're going to have problems. Hyper versus hypo. Hyperventilation. Too much, thank you. Wow, you guys are shy today for some reason. Okay. Hypoventilation. Okay. Too little, underbreathing. Hypercapnia versus hypocapnia. What is the word capnia referring to? CO2 levels. Okay. So hypercapnic is high CO2 in the blood. Usually they're in a state of acidosis. And then hypocapnic is low CO2. Low CO2. We typically, through the bicarbonate buffer system, you guys remember that in 202? In the bicarbonate buffer system, we exhale off a lot of our acid load. Right? So free acid moves into the bloodstream, right? And it's conjugated through this bicarbonate buffer system. And now you breathe off CO2 and water vapor, right? So that's how you clean your glasses, like, right? That's where the water vapor comes from because of metabolic exhalation. So if you're exercising, the reason that your ventilation rate goes up isn't just to supply you with more oxygen, it's actually to help breathe off extra acid. It's one of the reasons when you're done running, you don't automatically move back to regular respiration because there's an acid load that's still trying to get out of your body, and so your respiration stay a little elevated, right? This is all exercise science stuff. Stay a little elevated even beyond the ceasing of physical exertion. Make sense? All right, hemoptysis. Hemoptysis. This is blood in sputum or coughing up blood. Cyanosis, this is a bluish color to the skin or the mucosa, which usually is an indication that there's a decrease of oxygenation in the bloodstream, or hemoglobin is deoxygenated. Hypoxemia, decreased oxygenation of arterial blood, and then hypoxia is a decreased oxygenation at the tissue level or at the cellular level. So hypoxemia is in the blood itself, arterial blood specifically, and hypoxia is at the level of the tissues. And this is straight out of an anatomy physiology text. This is 202, second semester respiratory physiology. There's just a couple of things I want to highlight. I want to highlight this tidal volume, which is about half a liter. So tidal volume is that amount of air that you move at rest while you're sitting here. You're not exercising, okay? You're not under exertion. You move about half a liter of air in and out. And if you do a big inhalation, right? You go through a big inhalation, then your inspiratory reserve volume right here is what you cut into. If you go through a big expiration, your expiratory reserve volume is what you cut into. And then if you remember, there's a residual volume that you can never exhale completely, right? It's a little over a liter, about 1.2 liters. And the purpose of this residual volume is to make sure that your alveoli stay inflated. So it's as if you took all the air out of the balloon, you lay it on the table, right? It's not completely flat. It still has a shape to it because it has sort of an elasticity. And your alveoli and your respiratory tree is very similar. It is elastic. It has elastin in it. We'll talk about elastin. And there's enzymes known as elastase that break down that elastin, and it makes the lungs less elastomeric, right? And we'll see that in disease states. So that reserve volume that you cut into when you exhale, expiratory reserve volume, does not cut into the residual volume ever. That just keeps your lungs inflated. Okay? You guys remember all this? Total lung capacity in the average size individual is about 6 liters. But you're only going to be moving maybe 4.8 of it because of that residual volume. Make sense? So we've got diseases that can impact us when we inhale or make it difficult to inhale, and we have diseases that impact us or make it difficult when we exhale. We're going to look at both. And I just want you to remember on this graph from respiratory phys where exactly we're talking about. All right, first off, let's talk about a lung collapse. This one's kind of cool because a lot of you like emergency medicine, and so you'll get collapsed lungs that you'll deal with. Not cool for the patient, but cool in a clinical standpoint. Right? So lung collapse, atelectasis is the formal term for that. And it's due to an inadequate amount of expansion, which causes ultimately a reduction in oxygenation. So oxygenation at the level of the arterial system, arterial blood, would be hypoxemia, and eventually that leads to hypoxia at the level of the tissues. 3 different types. We've got resorption, compression, and then we've got contraction. So if we look at resorption, this is atelectasis, where we've got a obstruction that's preventing air from reaching the distal airways. You can see kind of on that left image here, we've got some obstruction that is a resorptive type of atelectasis, and you get this lung collapse where it's not able to completely expand to its full capacity. The air that's present becomes absorbed in the distal portion of that airway, and then you get alveolar collapse. Alveolar collapse, meaning remember those balloons that I'm talking about where you get gas exchange, they actually completely deflate and you have membrane touching membrane with no gap in between. Compression type of atelectasis, you can see on the far right image. Usually the compression is due to some type of infusion of fluid or an infusion of air. So in effusions that come from chronic heart failure, that's what the CHF is, and we're going to talk about that next week. Maybe we won't get to it next week, but we'll talk about it in the cardiovascular section. So when the heart is compromised and you have a large pressure head that the heart is working against, meaning that mean arterial pressure is high or blood pressure is high, the heart has to work against a pressure head to get it out of the aorta blood. And so it's inefficient, you get a lot of backup. And a lot of the backup of blood or fluid congestion goes to the lungs, because that's where the blood flow came from to get oxygenated. So now you have a pressure head in the lungs, and now you're actually getting a lot of extra fluid that sits on top of the lungs. And that can cause a compression type of atelectasis around the lungs themselves in the pleural space, which is why we refer to chronic heart failure. We also refer to it as congestive heart failure because there's a lot of congestion. In fact, if you talk to a lot of heart failure patients that are in end-stage heart failure, they'll tell you it's hard to breathe. It feels like somebody's sitting on my chest. And it's because of this situation where they've got a bunch of fluid that they're trying to inhale and expand the airway against. If you guys know anything about hydraulic brakes, the reason you have fluid in your brake lines is because fluid is not very compressible. Okay? So if it's not very compressible, are you going to win when you're trying to inhale and push against a volume of liquid that's there? No. So compression atelectasis. The second situation can happen where it's not fluid, it's actually air. And believe it or not, it's not quite as dangerous. You're like, really? Well, because air is actually more compressible than fluid. But it's still the same situation. So in a pneumothorax is where you would actually have, usually it's trauma, and so the chest cavity is compromised, and now the air pressure from the atmospheric air is the same as it is in that pleural space, and now you're working against this pressure head, and you've got air sitting in this space from the air that rushes in, right? If you guys remember back to respiratory phys, around the lungs it's slightly negative pressure. Slight negative pressure to allow for the lungs to expand and air to rush in. Because flow is from the difference between P1 and P2. That's the equation for flow. So if you have pressure that's higher here and pressure that's lower here, air is going to flow from high to low pressure. Make sense? So pneumothorax, you lose that pressure gradient, and now you're pushing against the atmospheric air, and you don't have the slight negative pressure to work in your advantage, so you have a lung collapse. And then the last one is considered contraction atelectasis. And in contraction atelectasis, this is where the lung itself goes through fibrotic changes. It becomes scarred, and the scarring of the lung prevents it from having its elastomeric recoil. And so you got this contraction event that takes place essentially globally, and now the lung is actually shrunk down. So 3 different causes of atelectasis. So let's look at chronic obstructive pulmonary diseases first. Chronic obstructive pulmonary diseases. So obstructive pulmonary diseases. So these diseases, which are going to include emphysema and chronic bronchitis, these are worse with expiration. Obstructive pulmonary diseases, by definition, are worse with expiration. It doesn't mean that you don't feel bad on inspiration, but the symptoms are exaggerated on exhalation or expiration. Okay? So, the 2 by definition on this list that are considered obstructive are emphysema and chronic bronchitis. We'll look down later at asthma and bronchiectasis as obstructive diseases, but they're not necessarily considered chronic typically because they don't necessarily last for all the time. Usually there's symptoms with an asthmatic, and then you treat, and then it goes away. Makes sense? You use the inhaler. There's rescue medications. Or in some cases with asthmatics, they're on daily medication to prevent the airways from becoming inflamed or irritated. So emphysema and chronic bronchitis, these two by definition stick around forever, okay? There's really no cure. And so we refer to these as COPD, chronic obstructive pulmonary diseases. All right, so let's look first at emphysema. Bless you. And in this portion of the lecture, we're going to talk about emphysema, then we'll compare it and contrast it to chronic bronchitis. And then we are going to move in for the rest of today into vaping, or e-cigarettes and vaping. Because I have a lot of new information on that topic, which is it's really actually quite popular in the medical news right now. It's pretty crazy. And so I think it's current. There's a lot of new information since when I looked at it last, so that's what we're going to end today's lecture. But so emphysema, chronic bronchitis, we'll compare and contrast the two, and then we'll wrap up today with vaping information. And there's a little bit of homework for you guys to do. There's a manuscript that I uploaded into this week's session. And we'll talk a little bit about that paper, but I do want you guys to take a look at it. End of the semester, challenging and pushing you a little bit more. Never a bad thing, but I want to give you guys an example of how you can go into the peer-reviewed literature and learn about some of these things with some of the knowledge that you do have. All right, so emphysema. Emphysema primarily affects the acinus, okay? And there's a loss of surface area, and you get a blowout of the alveoli. So when we say a blowout, meaning an increase in surface area, that's not a good thing. It's not an increase in surface area so you have better gas exchange. It's an increase in surface area because you've lost the architecture of the alveoli. So let me give you an example. So if we look at kind of a typical alveoli, right, kind of looks like this. Look like a little cloud. So in emphysema, what we would see is this thing would it would sort of do one of these. Okay? So you increase the surface area, but you lose the structure. So you have kind of these big pockets now versus these nice, neat little tufts. And now gas exchange is actually compromised, and the ability of the alveolus to facilitate gas exchange is compromised. So we get alveolar enlargement that's distal to the terminal bronchi, or bronchioles, excuse me, which is basically where the acinus is. That's the respiratory zone, right? So in the respiratory zone, we have the respiratory bronchioles down to all the way to the alveolus. So we've got respiratory bronchioles down to the alveolar duct and including the alveolus, which is known as the acinus, right? So here's a normal acinus, right? Here we've got our respiratory bronchioles, we've got our alveolar ducts, and we've got an individual alveoli. You can kind of appreciate two different situations here. The most common is the centra acinor. So it's in the middle of the respiratory bronchiole where you get this blowout that occurs. Para-acinor emphysema is at the end where you get this blowout that takes place. This is all due to a loss of elastic recoil. And the reason for a loss of elastic recoil is because you lower elastin content in the lung tissue. And we'll talk about how this happens here in a second. So cigarette smoking is more common as a centra acinor, and it's mostly seen in the upper lung lobes, not the lower. And the para-acinor, which is less common with cigarette use, it's more common in lower lung location, and is typically found in patients that wrestle with what's called an trypsin disease. So we'll talk about that in a second. It actually has a lot to do with elastin breakdown. This histology picture up top. So what I want you to appreciate from this, and we'll look at some more lung histology throughout today. So this is where this respiratory bronchial is coming in. It's coming down like this. There's another branch that goes down like this, down a alveolar duct and into an alveolus. And this second part of this alveolus is blown out right here. You guys see this? Same thing over here. This is a great shape, but this one is the alveolar duct. And here's where this alveolus is actually blown out and it's off the screen. This one you can see in the entire frame of the screen. This white space is an alveolus, but it shouldn't be this large. It's kind of looking like one of these right here. Was there a hand or a question?
Yeah. You said para-center. Is it para or is it pan?
Sorry, Pana Center.
Okay.
Pana Center. Yeah, thank you. Sorry if I misspoke.
Would the
So Centra Center and Pana. Pana Center. Pana Center. Yeah.
Would the histology be Pana-center?
This histology would be Pan Center because it's at the end. That's correct. Yeah. Okay. So let's talk about emphysema and how it gets going. It's not super clear what leads to it. It's also not correct to assume that every patient that's wrestling with emphysema was a smoker. Okay, that's an important piece for you guys to understand. And so like I characterized on this previous slide with pan-center, there's a underlying genetic predisposition for this that may have nothing to do with cigarette smoking. Now, if those patients smoke on top of it, it could be like a double whammy. But there's two main things going on in patients that we're aware of, okay? One is a protease anti-protease imbalance. And what I mean by that is there are typical enzymes that will be released within the lung tissue. So if you look here, you've got capillaries that recruit neutrophils into an area. You've got neutrophil elastase that gets released, okay? And this alpha-1 antitrypsinase blocks the activity of neutrophil elastase. So this is alpha-1 antitrypsinase. So this alpha-trypsinase that is present in lung tissue helps to neutralize this elastase that's being released by lung macrophages. Why would you do that? Well, remember the lungs are in direct interface with the outside environment. So you're going to get a lot of foreign invaders. So there's a lot of lung macrophages that are available, okay? Now they're typically not in an activated state, they're not proliferating. And so you don't want to be oversensitized to a foreign object and release copious amounts of elastase and degrade your tissue to a point where now it completely remodels. And so you've got a balancing act here of an antiprotease or a protease inhibitor. Now there are certain patients that have a deficiency in that gene. And so these patients that have a congenital mutation or a deficiency in this alpha-1 antitrypsinase don't have the ability to nicely balance the elastase that's made by lung macrophages. And so they have a predisposition for developing emphysema because of the elastase ability to remodel tissue. Does that make sense? So that's one thing that we know. Can you test for it? Sure. Do you want to know that information? I don't know the answers to that. Okay? I frankly probably wouldn't want to know the answers to that. The other situation is this antioxidant imbalance. So what I mean by that is, we know that cigarette smoke, tobacco, We also know that other types of pollutants kind of lead into vaping. Things that are in the air or the mist that we're breathing will contain free radicals. And those free radicals have a similar type of activity where they deactivate the normal activity of the antitrypsinase. Okay? So these free radicals will inactivate the antitrypsinase, and now you've got this reactive oxygen species pathway that's operating very similar to this congenital defect. So that's the second thing that we know. The third thing that we know, which should be on here, but I mean it's kind of we're alluding to it, is that the tobacco itself, nicotine, as well as the free radicals, they stimulate through interleukin 8 and TNF-alpha the recruitment of additional neutrophils or monocytes becoming macrophages into the lung tissue. And so they're aiding in the ability of these macrophages to come in here and increase elastase production. And oh, by the way, it's not just elastase. There's other matrix metalloproteinases that remodel extracellular matrix that are being produced by these resident alveolar macrophages that come in as they're being recruited out of the bloodstream. Just like you guys saw when we roll and tether in inflammation, this is an inflammatory response that's happening in the lungs. Does that make sense? So 3 things that we're talking about. One is there's a patient population that's genetically predisposed to this. They've got some sort of deficiency in alpha-1 AT. Then we've got population of patients that smoke. And smoking has multiple things that are problematic. Number one is the reactive oxygen species mimic this congenital defect, and they inactivate the alpha-1 antitrypsinase. And number 2 is they stimulate through the recruitment of additional white blood cells, more alveolar macrophages to show up and remodel that tissue in a negative way. You guys with me? So these patients of an emphysema etiology or clinical sequela, they have shortness of breath or dyspnea. We refer to them as pink puffers in the literature. You'll see a lot of terminology on pink puffers. And the reason is that, because of that, is there's a lot of extra energy associated with trying to exhale. Okay? They're often barrel-chested, and they lose a lot of weight over time, so they tend to be thinner because they're spending a lot of energy burning calories trying to breathe. Okay, so I want all of you to do an activity with me. Okay, you're going to take a deep inhalation. Okay, you're going to breathe out halfway, and then I want you to breathe from that tidal volume from then on out. Ready? So deep inhalation. Exhale halfway. Feel that? Don't you just want to have a big exhale? That's how they're breathing. They're breathing at the very upper end of that. Now you're all like, I'm going to pass out. And don't do it very long. So that's how they're breathing for years, and that's why they lose so much weight. And that's why there's a lot of exertion on exhalation, and that's why they become sort of pink in coloration. Okay, I want to contrast this with chronic bronchitis. I want to contrast this with chronic bronchitis. So if we look at emphysema on the right, and we're saying, and again, because we're in a classroom, we can have ideological thinking. We can say that there is a theoretical patient that is only wrestling with emphysema, and this is what it's going to look like. Right? We've got these blown out alveoli, and we're going to now look at pure chronic bronchitis. And we can, bless you, isolate this out into large airways as well as small airways. Now, what's the reality? Do patients only have one and never the other? No, of course not. You guys probably know by now that it's never that black and white. But for purposes of our class, we're gonna segregate them out and say, oh, it only is going to be this, or it's only gonna be this. So if I have a question on the exam, the spirit of the question is, tell me, ideologically, pure emphysema has the following. Ideologically, pure bronchitis has the following. I know I'm gonna get emails from you in the future like, yeah, you're right, Dr. Keller, it's never as easy as it was in your class because we've got patients that have all sorts of mixed clinical problems, okay? We're trying to sort out what's going on, and they got like 5 things happening. On top of that, they're alcoholic, you know. Okay, so compared to emphysema, chronic bronchitis means that they have a persistent cough. Persistent cough that is productive. 90% of them tend to be smokers, but not all chronic bronchitis sufferers are smokers. So we've got 3 different types: simple, chronic asthmatic, and chronic obstructive. In simple chronic bronchitis, we've got mucus is present, so it's a productive cough and they're spitting up sputum, right? They're making loogies, right? So it's mucus is present, but the airflow is not obstructed. Chronic asthmatic, there's intermittent bronchospasm in addition to the mucus, right? So now in this chronic bronchitis patient, they actually have bronchospasm where the bronchioles are restricting down. And then chronic obstructive is the worst type, or the most severe, where you would actually have mucus so thick that it's blocking the respiratory tree, and really it's only seen in smokers for the most part. Chronic obstructive. So, can you develop bronchitis as a diagnosed lung disease, as a non-smoking, healthy, college-age student? Yeah, of course. You know, they're gonna, hey, you've got some sort of lung infection, you're developing mucus, but it's productive, it's green, we're gonna put you on antibiotics because you have bronchitis. That is very different than a smoker who's been smoking a pack a day for 40 years, and they've had the same cough for 40 years. Do you understand? I always get those questions like, well, I understand, I had bronchitis last winter, Dr. Keller. See, yeah, you did, but we're talking about simple bronchitis, right? It was probably still difficult to breathe, right, if you have bronchitis. But we're talking about very different levels of bronchitis. You guys with me? Okay, so some students get caught up on that, like, well, I had bronchitis, it wasn't that bad. I mean, I had some medication and I got over it in like 2 weeks. Okay, well, that's up here, that's simple. Simple bronchitis, okay. If we look at the different airways, we'll see that the small airways, like the bronchioles, we get fibrosis that takes place around the bronchioles. We get airway obstruction, like, and this is in the situations most observed in chronic obstructive, where we've got airway obstruction at the distal airways. In the large airways, like the trachea and the bronchi, we'll get hypersecretion of mucus, we'll get rampant inflammation here, okay? And again, this is our chronic bronchitis, mostly in the chronic obstructive phase. So it impacts the large airways and the small airways in slightly different ways. To diagnose bronchitis is usually there's a persistent cough for at least 3 consecutive months in at least 2 consecutive years. So arguably, even with simple bronchitis diagnoses, you're being diagnosed a little prematurely. Because really there needs to be a persistent cough for 3 months. And I know people that are getting diagnosed with bronchitis, and I'm not arguing they've got something bad going on with their lungs. But you know, it's like, I've had bronchitis for 2 weeks. Well, technically, bronchitis is something that lasts for a couple of months. All right. So in this disease, similar to what we talked about with emphysema, we've got a loss of pseudostratified epithelium. A the loss of pseudostratified epithelium. So your respiratory escalator is compromised. And this doesn't happen in a couple weeks. This usually takes a few months for this to take place. But again, we're talking about the chronic obstructive type, the most severe. Okay? There's thoughts of an environmental trigger, meaning that there might be something that's happening within the air that we breathe, whether it's air pollution or whether it's cigarette smoke or vaping fumes, we don't know. That's going to upregulate the production of mucus by turning on the mucin gene. So now you get hypertrophy of submucosal glands, and this tends to begin in the large airways first, and then it moves to the smaller airways. And oftentimes, when you get extra mucus that's there and it's sitting there, you get an infection. The infection follows the sitting of mucus. So, in patients that are asthmatics, if they get a chest cold, oftentimes it'll result in some sort of lung infection. And part of the reason is with asthmatics, they get a lot of congestion in the chest. And if they can't get the phlegm out and it gets stuck down there, it turns into a chest infection. Okay. So in these patients, here's the, this is normal. This is normal epithelium up here. The pseudostratified columnar ciliated epithelium. And this is a goblet cell right here that's dumping out mucus. And this is pathological histology, where you can see all of this area with all of these purple nuclei. These are all inflammatory cells that are sitting within mucus, okay, in the lung tissue, in the alveolar spaces. These patients with clinical features of chronic bronchitis are usually referred to as blue bloaters. It's very difficult to find patients clinically that are wrestling with chronic bronchitis that were smokers that don't have emphysema. And so that's why the slide says with emphysema. That's most typical, is you get a patient that has chronic obstructive bronchitis and emphysema that present simultaneously. Okay? If the emphysema wins out, they tend to be thinner. If the chronic bronchitis is winning out, they tend to be more blue in coloration. And the reason for the blue, why do you guys think they're blue? What's that?
Hypoxemia?
Yeah, they're under oxygenated. Okay, they're not able to get enough oxygen, so their skin is blue in color. They have shortness of breath. They retain their CO2. They're hypoxic and cyanotic. They tend to be a little bit overweight. One of the thought processes on why is because metabolism is low. Basically, if they're starving for oxygen, their metabolism isn't able to give them the energy, and so they sort of just kind of lack of energy, sit and not do a whole lot. Okay, they have a lot of shortness of breath, so they're not going to be exercising because that's hard to do. They have cough with sputum, so it's a productive cough like we were talking about, and they have shortness of breath on exertion. Okay, third category for today, e-cigarettes and vaping. So it's amazing, I spent some time over the weekend updating the slides, because it's been 5 years since I looked at this topic. Okay, it's been 5 years since I looked at the topic. And over the 5 years, the field was very busy with a lot of accusations, but now we're starting to see some much more definitive decisions that are being made. And so I want to share with you some of these decisions. So this is a previous slide, it's probably the slide that you have, but mine's slightly updated because I used to say, are they safe? Not clear. Now I've crossed down, they are not safe. And I'll show you why. It shouldn't be a surprise. But the way these things work, in case some of you don't know, is they have a heater. And usually it's battery operated. They have a heater. It heats some sort of liquid that contains an active ingredient. And when I made this slide, really the only thing that people were vaping was nicotine. Now there's all sorts of things. You can vape with THC or CBD, which are some of the active components in marijuana, and obviously nicotine. You can vape without any active ingredient other than a flavor if you want, okay? Usually there's a vapor that you see, and that can be inhaled. The manufacturers have always claimed that they're a safe alternative to smoking, with no data to substantiate it. The FDA has always questioned the safety on these products, and in early years they tested the samples and found that they do contain trace amounts of toxic chemicals and carcinogens. Because a lot of thinking was, well, there's no carcinogens, not like burning a cigarette. There are definitely fewer carcinogenic agents. So cancer may not be a problem, with e-cigarettes and vaping. It might be that you won't live long enough to develop cancer. So I'll explain to you here in a minute what's going on, okay? So this is kind of where things have sat for a while. I want to show you, I didn't make this a slide because it's pretty cheesy, but this is from a USA Today. I was traveling and I was years ago. You can see the date up here, April 18, 2014. So it's almost 6 years old, right? April in the spring, this article would be 6 years old. And so almost 6 years ago, I told this, and we got opposing views and our view, and I'll post this so you guys can read it. We're not going to spend all the time here, but so our products can help end smoking over here on the right. Combustion tobacco cigarettes will prematurely kill almost 500,000 Americans this year. This devastating trend is projected to continue for years, but is not inevitable, right? E-cigarettes deliver, second paragraph, deliver nicotine without combustion and can help end smoking. So this is the position over here, okay? It's almost like a debate, okay? And one of the manufacturers, one of the early manufacturers called Enjoy. And then over here, e-cigarette sellers take a page from big tobacco. So over here, this is opening up, which is the other view of the manufacturers, talking about how dangerous this potentially could be. Right, down at the middle column at the very end, the dangers of e-cigarettes may not be as obvious as those of traditional smokes, but new problems are emerging. This is almost 6 years ago. For example, the nicotine-laced liquid the device is used, which comes in small vials and large containers, can be toxic if touched or consumed. Calls to poison control centers about misuse, mostly by children, have risen to 217 a month this year, almost 10 times the number in 2011. So like 217, is that a big deal? Well, wait, numbers get worse. We're going to talk about numbers. So this was back in 14, and I saved this article, and I just wanted to show it to you because we've been having this debate for half of a decade, for sure, 5 years. Okay? All right. So now let's go to where we are today. All right, so now we're going to go to another article. This is on the website of the Center for Disease Control, okay? This is a great resource for you guys to read. Outbreak of lung injury associated with the use of e-cigarette or vaping products. So now there's actually an acronym for this. It's called EVALI, E-V-A-L-I. Right? E-cigarette, vaping associated lung injury, EVALI. It's got its own acronym. Center for Disease Control, this website, you can read all this. This is updated on November 14th, that's today, right? Oh no, this is actually last week, sorry. November 14th, that's today. So CDC has identified that vitamin E acetate is a chemical concern, right, associated with this lung injury. I'm going to show you what this lung injury is. Now, vitamin E is well used, right? You find it in lotions. You can go buy vitamins and swallow a pill of vitamin E. But the problem is, as a cutting agent in vaping what that means is when they pharmaceutically manufacture these solutions, a cutting agent is used to lower the amount of the active substance that needs to go in. So you still have substance to vape, but it's not 100% nicotine or 100% THC, one of the active ingredients in marijuana. And so they use vitamin E, but it's never been tested as an inhalant. And this one is actually causing remarkable problems. Okay? All right, so let's keep reading. Okay, I've got these numbers here. So this is the website. This is where all my information came from. And I want to go to this particular slide. This is the Washington Post. This particular slide, you can see November 12th. This is just last week. So this data is only a week old. Doctors in Michigan said Tuesday to perform what they believe is the first double lung transplant on a patient whose lungs were damaged from vaping, highlighting the extreme steps medical experts are taking as they confront a nationwide rash of vaping-related illness. The medical team from Detroit's Henry Ford Hospital said the patient, a 17-year-old male, underwent the roughly 6-hour transplant surgery October 15th. He spent a month on life support machines after suffering complete lung failure at 17 years of age. Okay? And would have faced certain death without the operation, according to doctors. The team's family described him as an athlete who was in perfect health before he was admitted to the hospital in early September with what appeared to be pneumonia. Within weeks, his condition had been so dire he shot at the top of the national transplant list, where most patients spend months waiting for a doctor. Probably because he was 17 and he was in good health. So the only thing that was wrong with him were his lungs. Okay? So that's good news. All right, so I want to show you this particular video. Let's see if my audio will play.
On the 15th of October, our team, the lung transplant team, performed what we believe is the first double lung transplant done in the nation for a vaping injury victim who's a teenager. Essentially, the reason we wanted to bring this case to public attention because of the epidemic of e-cigarettes and vaping-induced lung injury that we are witnessing in the country. As of last week, over 2,000 cases were reported to CDC. Close to 40 deaths were confirmed from lung failure related to this injury. It's a senseless disease process, totally preventable death. And our teenage patient would have faced certain death if it weren't for the lung transplant happen. The picture of the lung after transplantation on the left side, and the picture of our recipient's lung before, when we first transferred him down here, showing the destruction that occurred to his native lung, the amount of pneumonia that was there, and the...
Okay, so I'm going to show you some other pictures because it's not super clear from another article on eVali. Okay, this is going to go into a cat like on a treadmill here in a second, which is really distracting. So we're just going to go back to the regular presentation. But I mean, basically, you said what I said, but I wanted you guys to hear it from the surgeon. You can read this for yourself. You can look at the whole thing. I encourage you to dive into the CDC website. On the CDC website, there's actually a button. Let me show you that link. There's a button here that says, where is it? Latest outbreak information is updated every Thursday. So the information I have is from last Thursday. So this Thursday and then on Thanksgiving, you can go and just click the button and see how many more people have died. It'll be quite interesting, okay? I know, I meant that very facetiously, I know. Okay, so this is from the CDC as of last Thursday. You can take a peek. This is more on that. All of these slides came off of that website, Center for Disease Control. Okay, you can see the number of cases. We've got 150 to 200 cases, or just shy 199 in these states that are highlighted in green. Arizona's not looking too hot. Well, I guess it's not too bad, is it? Is it like 10 to 49? Doesn't look too bad. Utah, I was surprised by Utah. Utah being high. I thought Colorado would be higher than Utah, but shows what I know. So this kind of shows you where everything is taking place. Now I want to highlight this paper. I put this paper in the BB Learn folder this afternoon, so you guys can read through the whole thing on your own. So this is lung biopsy findings in severe pulmonary illness associated with e-cigarette use, vaping. You can see the list of physicians that are shown here. This is from the Cleveland Clinic, a very well-respected facility, the Department of Pathology. Probably know what they're talking about. Keywords: vaping, vaping-associated pulmonary illness, electronic cigarettes, e-cigarettes, dabbing. Is that a thing? Dabbing? Is that another? Dabbing, gotcha. All right, see, I'm learning. Lung pathology, lung biopsy, diffuse alveolar damage. Diffuse alveolar damage, we're not going to talk about today, we're going to talk about on Wednesday. Diffuse alveolar damage, DAD, not the great kind of dad, it's a different kind of dad, okay? Organizing pneumonia, acute lung injury. So, the objective, the aim of this report is to describe the lung biopsy findings in vaping-associated pulmonary illness. So, folks, this is a disease that we did not know about when I showed you that USA Today paper with Jenny McCarthy like 5.5 years ago. This disease we just invented in the last 5.5 years. Amazing, okay? So, are there going to be new diseases that you all are facing in the future? Absolutely, okay? Stuff that we didn't even know existed, because we're going to come up with new technology and new things, and there's going to be new risks. Use some common sense, okay? I was very skeptical about vaping, and I would tell students, and I'd say, well, what do you think? You think it's good for you, or you think it's bad for you? I don't know, there's not enough data. I mean, it's like brand new. I said in 10 years, we'll see. My suspicion has always been, if you can see the air you breathe, probably not something you should be breathing, okay?
Are most of them THC related? Because in all the articles, that's what it says.
No, not all of them. Most of them are related with vitamin E acetate. And there's been incidents associated with vaping that's not vitamin E. These are the ones that are most severe, where you're atomizing or you're basically vaping fluid and it's becoming airborne and there's particulates in it. But the problem with the vitamin E acetate is it does a lot of lung damage. It basically sticks to the lung because it's a sticky substance and it's hard to get out. So your lung isn't designed for removing kind of like that goopy vitamin E. If you've ever had a vitamin E gel, have you guys ever, or taken a vitamin E caplet and open it up? It's like gooey, okay? Right? You're like, you do? Yeah. I mean, that was me as a kid. Oh, let's cut it open. See what it looks like on the inside. All right, so here's CT images from this paper, so you can read through these CT images from this paper. This is a patient that, different patient than what we were talking about on the video. This is a totally different paper, okay? But this one was published in 2019. You can actually see here at the bottom, this is almost a preprint, because it doesn't even have page numbers. This is American Journal of Clinical Pathology in 2019, so this is literally fresh off the press. So what we're doing is we're going on CT imagery, patients laying down, and you're going from toe to head or head to toe. And so we're basically looking here. So it's as if I'm laying on the table with my feet facing you, and you're looking at a slice right through my lungs. Does that make sense? Okay. So what we've got here is the patient's left is going to be on your right, and the patient's right is going to be on your left. You guys with me? And all of this white sort of shadow shouldn't be there. And as we go deeper down, you can see there's more exaggerated white shadow. And so what we've got is, we call these opacities within the CT imagery. And this is showing areas, this is what pneumonia looks like. If you have pneumonia on a chest x-ray even, you'll see a bunch of white where it's supposed to be black. So what is it supposed to look like? Here's a normal lung CT. And here is this image, level B, I picked this one, compare and contrast an eval lung under CT. These are data we did not have 5.5 years ago. This is data that was just published this year, 2019. It's so new, it doesn't even actually have a DOI number yet. It's available, you can download the PDF, and I gave it to you. But this is real stuff, folks, okay, happening right now today, real time. Okay, last piece of histology, or information, actually. Let's look at this lung histology. From the same paper, and there's more histology for those of you that after a turkey dinner, you want to spend a little bit more time looking at histo. So on this histology, same kind of thing. We've got alveoli. Let's say this one, for example. This alveoli is full. This is supposed to be white in here. And what are those cells? What do you guys think those cells are? So they weren't. They're neutrophils. That's fine. That's an okay answer. It's late. Don't tell anybody it's in the figure legend. The answer. Macrophages, very good. They're called foamy macrophages. What are foamy macrophages? Well, the foamy macrophages means that they've taken up debris. Right? They're cleaning up debris. They're cleaning up particulates come out of the vapor, maybe some carcinogenic agents. There were glycol-like substances that are typically used in vaping products for nicotine. So there could be some glycol-based products that they're gobbling up. Or in the case of vitamin E acetate, they're gobbling up, they're trying to gobble up the vitamin E. As you make your way, see more of examples of these macrophages in panel B. Panel C, this is bronchial alveolar lavage fluid. So lavage is not a comfortable process. That means that they put a tube down your trachea, they get it into one of the primary bronchi, and they literally flush it with saline, like they're gonna drown you, but they don't do the other side. And then they pull the fluid out, okay, to clean out the alveoli. And then now that they've got that fluid, they put it under a microscope, and now you've got, these are macrophages that are found in the lavage fluid. Okay, that's what panel C is. And then they can stain these with a marker to determine that they're actually in an activated state, and that's what this oil red O positive macrophage marker is on the right panel. So in these patients, you can see under CT, they look like they have pneumonia, right? They've got a massive inflammatory problem going on, such to the point that they're losing lung function. They're in total lung failure in the worst case scenario, like with the 17-year-old patient up in Detroit. And just to point out, this is normal lung histology. Look at how wide open and clean the alveoli are. And this is this evali lung from that one particular patient. There's a full-on like island of cells in the alveolus that's not supposed to be. Okay? All right, so what do we know to date? These are data that came off of that website. Again, Thursday you can click on an update, but as of 11/13/19, we have 2,172 cases of e-cigarette or vaping product use associated lung injury, evali, that have been reported to the CDC. That's U.S. numbers only. U.S. numbers only. That's all the CDC really focuses on. World Health Organization has additional data if you want to dive into that. 42 deaths have been confirmed in 24 states. It appears that vitamin E acetate is the main issue. I think there are potentially others because there's investigations going on right now that there may be more than one cause of evali. So, is it safe if it doesn't contain THC or CBD? I would say no. I would say that there's too much information and there's too much data to demonstrate now that vaping or e-cigarettes are actually harmful to your health, and they are not a safe alternative to traditional cigarette smoking. Okay? That's a long warning label to go on the box next, but they probably will have to have something come out. Questions? Okay, Nancy.
Is there, so does that, I mean, it kind of insinuates what you stated, that if they find a new way to manufacture this without the vitamin E acetate, but then it's like safe, but then, you know, what's next?
How are they going to test that?
Yeah.
Are they going to test it? They will be required to test it now, most likely. Right? So, yeah, I mean, the comment's a good one. If you're, what's the polar side of the argument? The other side of the argument is free enterprise, right? Free enterprise in this country. So the manufacturers say, Well, I mean, what if I switch out to some other cutting agent? What if they use saline, okay? They're still gonna have to do tests to demonstrate its safety. Because now all this data is there. You guys with me? The other thing that's all over the CDC, and I want you guys to hear this, is they're very, in the FDA website, there's huge warnings about buying e-cigarettes or vaping products from kind of sketchy operations. They don't say it that way, but you understand what I mean? Like you can go on eBay, you can go on Craigslist, and you can buy stuff. Like I looked all this stuff up because I was trying to kind of re-immerse myself in this space. So there are mom and pop organizations that are just doing this stuff, and they have no idea what they're doing. They have no idea what they're doing. And you've got children that are using and consuming these products. That is a huge public safety issue. It's a little bit different if, you know, a pharmaceutical manufacturer or a company that's under jurisdiction of the federal government decides to go into the business and make e-cigarettes and vaping. Is it citizens' rights in this country to do this? Yeah, of course it is. But it's also the right to know if it's safe or if it's not safe. And that's the perspective that the CDC and the FDA are taking is we need the public to be aware of what's happening. So could they do new chemistry and figure out an alternative way to offer these products? I'm sure they can, okay? They're not all bad people, right? And they're not all stupid. There are people that know what they're doing. Could they figure that out? Yeah. Are they gonna have to do testing to prove that it's safe? Absolutely. You guys with me? So that's kind of where the space is now. But you guys, presumably, if you're gonna be interacting with patients, you're gonna be seeing patients in your lifetime that have been wrestle with this EVALI, which is, again, a brand new pathology of lung disease that was just invented, at least in the last 5.5 years, as best as my records can show. That's from a newspaper clipping, but, you know, in an airplane club, but you know, that's pretty good documentation. There's another question in the back? Okay. All right, we're gonna pause there. We're gonna come back on Wednesday, and we're gonna start talking about asthma, right?